Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and writer by trade that has been working with CCF for 10 years, 1 decade.
Wow.
Big chunk of my life, a big chunk of my career, and I could not be happier, more fulfilled by the work that we have done. And in that span of 10 years, going on 11, I think now, we have created a large library of video content, some live video series like what you're going to watch today, but also documentaries, patient-centric stories, treatment-based videos, a lot of stuff we have covered, but all with the same mission in mind, folks, and that is to raise awareness and educate people about neuroendocrine tumors. That is what we are here to do. This show is pretty awesome because we do that by way of our experts, like who I will introduce in a moment, and I'm quite proud of the community that we've cultivated here within the show. That's you all in the audience. And so if you are new, I want to say welcome. If you're a regular, as I see many of you are, you're already telling people hello and saying where you're from. I always get so excited to see where everybody is signing on from. As always, Canada is in the house very strongly. But I'm sure we will see people from all over the world. So if you're new, introduce yourself. I promise you the community will embrace you. Before we start, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Very simply, without their support, we wouldn't be able to do the show. We also have this disclaimer from them that we like to say at the top of each program. And that is that the opinions expressed by the guest presenter today, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on the opinions or information expressed by our guest today and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so as disclaimers often are, a lot of words there. The real takeaway is that last line. We're going to give you some great advice, or our guest is today, and hopefully answer a lot of your questions. But by no means do we or our guest know your specific case. So take that information and that advice back to your home team, which does, and make the best plan and path forward for you. Because if there's anything that I've learned in these past 10 years with CCF is that each case of this disease is unique. Therefore, each plan and path forward is as well. So I am very excited to welcome a new guest to the show, one who I'm quite fond of already because he's got an awesome personality, and I'm happy to welcome him to the show. Dr. Rondell Graham, welcome. Thank you for being here, sir.
Thanks so much for having me, Rain. Congratulations on getting to 10 years and going with the Carcinoid Cancer Foundation.
I appreciate that. And this show's been going on almost 2 years now. So we've been putting in work, Dr. Graham.
Most definitely you have. And I think this is so important for patients to have the opportunity to learn more and to be active advocates for themselves as part of going through the treatment process. So congratulations for that. And thank you for having me.
Yeah, absolutely. I couldn't have said that better. I totally agree. For those folks that might not know you or what you do, tell us a little bit about yourself, where you work, and the role you fill in the neuroendocrine tumor community.
Thanks, Ryan. So I'm a Rondell Graham. I'm one of the GI liver pathologists at Mayo Clinic in Rochester, Minnesota. And so a large part of our work is caring for patients who have neuroendocrine tumors. And the way in which we do this is by making diagnoses and interpretations from biopsies and resection specimens. So tissue specimens taken from patients, we interpret them to confirm a diagnosis of neuroendocrine tumor because sometimes they are mimics. They're not neuroendocrine tumor, but they mimic it closely. And the reverse is true. Sometimes a neuroendocrine tumor is mimicking something else.
Right.
So a huge part of our job is making accurate diagnoses. And then there's some additional points of clarification that we provide in our testing. One, we like to try to identify the primary site because there are neuroendocrine tumors from different sites. And then we try to provide a classification for that tumor, which gives some idea as to how the tumor will progress. And that's often done by assessing how rapidly it's proliferating. So I'm involved in tissue-based diagnostics, and I work collaboratively with medical oncologists and with radiologists who are also part of the team. But neither of those areas are my specific area of expertise. My specific area is in pathology or in diagnostics.
Got it. Lovely. Well, Dr. Graham has promised me that no question is out of bounds. And so go ahead and start sending your questions in. I have a few already that I'll get to. But folks, a couple other things before we fully start. You can go ahead and start sending in your questions. By the way, it looks like Ajay from Nepal is in the house. Love seeing that. Now our international friends are here. But folks, listen, we get a lot of questions. I've already asked you to start sending them in. So inevitably we don't get to them all. That's why we have the show every week, right? So if we don't get to your question, though, we want to help you. That's our job here. So I would encourage you to reach out to CCF. You can message them privately here on Facebook, or you can reach them at carcinoid.org. They will get you the information that you need. I will also recommend that you look at our database that I've already mentioned of videos, even the Luncheon with the Experts episodes. We've done, I don't know, hundreds of these at this point, but also all the other videos. There's a video for pretty much any topic that you can think of. We have. So use those resources. This is what we do it for, folks. But a couple of things that I ask from you every week. And you do a very good job, but I will not stop asking. One, if you know someone who should be here, we're going to have this available for a replay. As soon as this is done today, it will be posted. It'll be evergreen on Facebook. Next week, it'll be on YouTube. So the replay is valuable, of course, or if someone doesn't make it today, but the real value is if you're struggling with something or your team is getting a question across to our guests today. So if someone needs to be here that you know, tag them in the comments, share the video, let them know, remind them the show's going on. We're here every Thursday at the same time, but sometimes people get caught up. So let them know what's going on. And my second ask is, if you see a question in the sidebar that you have and you're interested in the answer to, there's a little like button under it that you can click. Tap that and it lets me know there's a demand for that question. As I said previously, we get so many questions, we inevitably can't get to them all. If I see 8 people have this same question or are interested in that topic, I'm going to make sure to get it across. Okay. So that helps me do my job, which is to serve you. All right, let's get into it, folks. I see questions already coming in. I had one. I'm going to squeeze mine in first because you said this word about mimicry, right? About mimics. And I love that. And I may be aware of what you're talking about. I certainly know that NETs can mimic other conditions or diseases, but you mentioned the mimics of neuroendocrine tumors. Could you just go elaborate a little bit more about that for me? Like
Yes.
what are some of, yeah, go ahead.
Yeah, so I think both things are true. You
Okay.
can have nets being mimicked by other tumors,
Mm-hmm.
and you can have nets mimicking other tumors. So, in the context of a liver biopsy, which can happen for multiple liver lesions, or even for a solitary lesion, you can have hepatocellular carcinoma mimicking a neuroendocrine tumor on histologic grounds alone. And what I mean by that is when we look through the microscope or we look at the digital slide, we are seeing a tumor that is composed of big eosinophilic cells,
Mm-hmm.
and that has a differential diagnosis. There are a range of things that can have that pattern, that look. Hepatocellular carcinoma is one, renal cell carcinoma is another, and so too adrenocortical carcinoma. All uncommon, so liver tumors, adrenal tumors, kidney tumors, but they all can mimic a net histologically when we just look at them under the microscope. There's some other things too that can mimic net. Again, it depends on where the biopsy is from in the context, but we can see that mimicry happening in the context of breast lesions. So in our practice, which is a large practice with lots of complex patients from around the world, we've seen patients originally interpreted to have breast cancer who actually had nets. So that
Wow.
can happen. That's a really unusual thing. But
Okay.
to illustrate how nets can mimic other things and other things can mimic nets.
Got it. Thank you for that. Yeah, I do hear some questions about any affiliation between breast cancer and NETs. So that's interesting that you kind of mentioned that. But we've got questions coming in already, Dr. Graham. So I'm going to go ahead and pivot to the audience. One that the first one from Rita, I hope I'm pronouncing that right, Reta, says, good morning. Can you tell me, this is a common question, can you tell me if there's a general genetic test for NETs? So my mother had it and now I have it. And this isn't necessarily uncommon from my experience from the outside. I am concerned about it being tested for a genetic component for my children, which is an obvious concern for people like Rita. So what are your thoughts on that?
So this is a good and important question. I think without knowing the specifics of Rita's case, and I think she would definitely need to discuss this with her healthcare providers. There are some scenarios where nets may seem to occur syndromically or occur in families, and one of those scenarios will be the multiple endocrine neoplasia syndromes. And so I think if she has that concern, that consideration, it'd be worthwhile to bring it up with her providers, and from there they can go through the counseling and what tests there are that are available, and then kind of proceed with next steps. So in multiple endocrine neoplasia, there are which is a number of syndromes. So it's not just one syndrome. There's MEN1, as a for instance. There's MEN2, A and B, but they're clusters of tumors that occur together, and then they travel through families, as it were. And so, if she has been, diagnosed, and she has a relative who's been diagnosed, in this case her mother, it'd be reasonable to raise that possibility with her providers and to be evaluated. Another thing I would suggest, there's some data that have been published from a number of groups. Know that we're in a molecular era with lots of molecular testing, showing that people who present with advanced malignancy, meaning an advanced cancer, may find that they have in the evaluation or the workup for that tumor, may find that they have a hereditary predisposition syndrome. So
Hmm.
I think it's certainly reasonable for people to raise this possibility with their healthcare provider, their physician, their nurse practitioner, and to begin the steps to look into it.
Got it. Thank you. Um, Dorothy had a question for the community, folks. So I just wanted to call attention to that. Does anyone else have wacky sleep patterns? Some days I need a nap and still can sleep all night. Other times I'm awake all or most of the night. Is that just me? So I always appreciate how you all step in and help each other, sharing your own stories. So just wanted to make mention of that. Also, hello to Ritva from Finland, our friends from Scandinavia, sending love out there. That might have been the first time I've seen you. So if this is your first time to the show, I want to say welcome. Appreciate you being here. Okay. So you also mentioned, and I know this is an issue for people. I am not an expert, but I have had enough conversations where I pick up a little bit here and there and can see patterns. So I know you mentioned the trying to find the site of the primary, and sometimes I know that that's a struggle for people to find that, and then that impacts obviously how you can approach and treat the disease. So tell me a little bit about some of the common struggles with finding the primary. If you can't find the primary, what do we do then?
So this is a great question, and it's an important area of challenge,
Yeah.
which is finding the primary site for a well-differentiated neuroendocrine tumor. As is kind of embedded within your question, there are a number of potential sites, and from a pathology vantage point, where we help out is we look at applying a variety of different markers to see if the tumor cells express those markers. So the tumor cells may express markers related to where they are from, in the way sometimes that individual will have characteristics that may reflect where they are from, right? So they might have things in their home, there might be dishes that they cook that might reflect where they're from. Tumor cells have labels that we interrogate to determine where these tumor cells may be from. And so we work together with radiologists in this regard because radiologists do have some special scans that they can do that can help pinpoint where neuroendocrine cells are, and that might give us some information. And of course, we work with surgeons too, who may sometimes remove some samples that may help us to identify it. Sometimes it can be really challenging because it's not unusual for a primary net to be small, but to have widely metastatic disease to the liver or multiple liver lesions,
Mhm.
or to present with a really big liver lesion, or some combination of the two, and us will try to figure out where it's from. So we do have a number of markers that are available to us. We have there are a couple of markers that are specific for lung, that can help us point to lung being primary. There are a couple of markers that point to the GI tract, and one in particular that points to kind of the lower GI tract. And so we have a range of markers that we can use, but none of them is perfect. So they all have a sensitivity that's less than 100% and a specificity that is less than 100%. And
Hmm.
so we try to put them all together in context to be able to help point us to the correct primary site. And I would say that what we hope to achieve, and I would say in general, we kind of have, I would say the markers have an accuracy of the order of 90%. And so I would say that in our practical experience, in my practice, I think that in 9 out of 10 cases, we'll be able to find a primary site. But because net is not super rare, it means that there are cases where we won't be able to. And so sometimes radiologic imaging is really helpful in helping us to kind of identify what's most likely.
Got it. Thank you. And thanks for your question. Oh, that was my question. But Effie has the next question, and this is back to mimicry, which we discussed just a few minutes ago. So she's like, mimicry is very interesting. What might be the possibility of a microprolactinoma being a net? Is there a way to tell other than biopsy? And in parentheses, she establishes that she has a lung net with dip neck.
Okay, wow. So a challenging question and a
Okay.
complex one.
All right, let's break it
I
down.
think without so my area of expertise will be if there is a biopsy sample. I think there are markers that can be applied to help make that distinction. I think I would say that the best people to address how you would handle that without a tissue specimen would probably be a net oncologist or oncologist focused on that. One thing that may be helpful, and I think would be reasonable to share, is that in general, micro pituitary adenomas usually pursue an indolent course, and so usually are confined.
Got it. Understood. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts of Carcinoid Cancer Foundation program. We're here with Dr. Rondell Graham today from Mayo Clinic. Great questions already. We're going to keep plugging along. Next one comes from Sean. What kind of nets would cause full-blown flushing attacks and symptoms similar to severe allergic reactions and vomiting, all at the same time, immediately after eating? And where would a person start to look? So he's a little bit frustrated, it sounds like, and confused.
This is a really good question, Sean. Thank you for your question. What you describe are the features that are typical of carcinoid syndrome. And this can happen with a variety of different nets. The crucial thing is that the carcinoid syndrome is mediated by serotonin and its metabolites. And once the level of those chemicals is in excess of the metabolic capacity of the liver, you can have those manifestations. And so those manifestations can happen whenever the tumor is able to put those chemicals into the bloodstream beyond the liver, meaning that it gets into the bloodstream rather than circulating through the liver, which can actually reduce the level of those proteins. And so this can happen when a patient has a disease involving the liver that might be extensive, or when those nets are beyond the liver in the circulatory system. So to kind of put that in I would say more general kind of terms, if the net is present in the lungs, it will be able to enter into the bloodstream and circulate in the body, having those effects. If there are multiple nodules present in the liver, the same thing can happen. Or if there's an amount of nets that is so great that the capacity of the liver to metabolize those chemicals is overwhelmed, then a person can present with that manifestation. So the typical scenario will be if we would say beyond the liver in location, as it relates to circulation, or beyond the liver in terms of capacity. So a wide range of nets can do that, but that is an important complication which you described.
Got it. Thank you very much. Next question from our friend Pat. What are the lung markers you just referenced a few minutes ago, that there are specific ones? Could you elaborate on that a little bit?
This is a good question. So the two markers will be TTF1 and the other one will be OTP. So the latter marker I think is really, really uncommon. I'm aware of it being at one academic medical center. TTF1 is widely available. TTF1 is quite specific, but not as sensitive as the other marker, which has a pretty high sensitivity and specificity. So those are the two markers that exist. and pathologists in academic medical centers certainly will be aware of it, and pathologists who are working with colleagues in academic medical centers will be aware of them.
Got it. Thank you. Thanks, Pat. Good to see you. From Hannah, should someone who has had surgery to remove a Ki-67 2.2% typical carcinoid tumor from their lung via lower left lobectomy and thoracotomy undergo any other testing aside from your annual CT scans?
This is a good question, and I think one that's really best reserved for the surgeon and the oncologist doing follow up for that patient, because we want to make sure that patients are getting the right information and safe information, and there are lots of details which may be a part of that patient's clinical care that are not part of the question. So I would say I would consult with them to make sure that your decisions are informed by all the things that they're thinking of. It is true that well differentiated or typical carcinoid with a Ki-67 of 2.2 will be expected to have a really good prognosis. So that's a feature of that description. But I still think when it comes to follow up, it's really important to pay attention to the information that's going to be provided by your providers, and I would say they will have a lot of context and a variety of other data points that they're going to consider in making that decision about follow up.
Got it. Thank you so much, and thanks for your question. We actually have a few about the genetic or hereditary components of this disease that I've seen, Dr. Graham. So the next one comes from Melinda, who says, my mother passed away from adenocarcinoma of unknown primary 15 years ago. Excuse me. It was before I found out that I have nets of the lung. I also have dip-neck and MEN4. Do you think any of this can be related?
This is a really good question and a challenging question. On the so the It's a question of probability if they can be related. I'm not aware of a direct connection between what was described, but it doesn't mean that it's not impossible. And the reason for this is that the when it comes to genetics and hereditary syndromes, the complexity is incredible,
Mhm.
and there are some things that are unique to specific families and may not be widely known about. Adenocarcinoma of unknown primary in general um, can happen to a wide variety of patients and doesn't have a specific genetic linkage. So there wouldn't be a specific thing that we could say, okay, this points to this particular abnormality. I'm sorry to hear about her mother's passing, and hopefully she'll be able to find some helpful answers relative to her own condition. What I think would be really useful in this scenario is if she were to construct a family tree. She could use on a piece of paper in her own handwriting to write the various illnesses that affected her family members, and focus on those that were neoplastic, and then include herself in the family tree and to bring that to an appointment with her providers. This is commonly how genetics providers will look at that information
Mhm.
with a family tree, and it will give them some insight as to the likely or the probabilities of things that need to be considered, and give them a window into what would be appropriate next steps.
Got it. Thank you very much. Ronald has a question. I'm not sure if we covered this earlier in talking about. We're still in the hereditary space. My husband had genetic testing to evaluate if he was on the correct treatment course and if any clinical trials might be beneficial. There was only one, however, it was far away. So the question is, what do we look at in the testing that would tell us if he had a hereditary factor or component?
So this is an interesting question too. It would depend on what testing they're referring to.
Fair.
So that's the part that we would need to get some more information on. When people are looking for hereditary components, or when physicians are looking for this, or genetics providers, they're commonly looking for something that happens consistently in families. So something that is inherited and is so-called autosomal dominant
Mhm.
would tend to occur in every generation of a family.
Interesting.
Something that is autosomal recessive, meaning not dominant, would tend to skip a generation. So we're looking at how a disease or a manifestation is present in the family, and there's a layer of of complexity on that, which I didn't get into, which is referred to as penetrance. So a person may have a disorder, but because of the penetrance is incomplete, they may not have a manifestation. So they have the genetic code, but not the manifestation. That is part of the concept of penetrance. So we're constantly looking at the family, how a disease moves through a family, how it's inherited. And the next component in terms of testing we will look at will be blood tests, looking at a variety of different genes which we know to be mutated or to be altered in individuals who have multiple endocrine neoplasia. So we're looking at how disease moves through a family, a collection of diseases moves through a family, and then we're looking at blood tests, looking for what we would call germline mutations. And so the provider will usually give you a report which will describe some pathogenic alterations, or they will read that report. And that information will give you some insight as to whether or not what you're looking at or where you're considering is hereditary or not, or whether or not the genes are mutated or not. So I'll give one last example for that. If you were to have tested for mutations in menin, or for example, you're looking at MEN type 1, they would look to see whether or not you have mutations in the gene responsible for that. And when they do that testing, they will get a result which will either confirm a mutation, it may find something of uncertain significance, or it may be normal.
Got it. Thanks, Ronald, for your question. And if you have any, this goes to Ronald and anyone, if you have any follow-up information or additional questions that pop up and we're still on the call, send away. We'll try to get to it. Next question. This is interesting, from Michael. Do you think they still have a sample of my biopsy from 25 years ago?
This is a really good question, and I think the answer will vary depending on where the biopsy was done.
Yeah.
So there are some institutions who keep biopsy and tissue samples indefinitely, and so there may be samples there from more than 100 years ago, theoretically.
Crazy, right?
In some places. There are some places that will have them for shorter periods of time, and that is driven. The decision making around that is driven in large part by what is required by regulators, the groups that establish the standards. So I would say it's not unusual for a specimen to be there for 10 years. To be there for 25 years is unusual, but there are some places that keep things indefinitely.
Where do they keep them? What's the storage like?
So it's a great question. They are usually kept in a warehouse type facility,
Okay.
where there's usually some appropriate controls to make sure that the atmosphere and the environment in
Yeah,
that
that's what I was.
facility are appropriate. And they usually are curated with identifying information for the patient and for the diagnosis. And those facilities can be quite large and are usually very carefully secured, as you would appreciate, because the material from patients is very important and needs really secure stewardship. And so that's the typical setup for patient materials.
Got it. Thanks. From Mary, I had a lot of lung net questions today. I had a typical lung neuroendocrine tumor that removed in 2012. And then I had an atypical lung net removed in 2018. So the question is, how common is it for patients to have both typical and atypical?
That's a good question. I don't know a specific number for that. I would say, as I listen to her scenario, it sounds a little bit unusual to me. And I should clarify too that my specialty in net is related to the GI tract, so that's what I see most commonly.
Yeah.
And I would say in the GI tract, it's not unusual for us to see a patient have nets of various grades. That certainly does happen. I don't have a specific number for the lung, though.
Got it. And look, this is a question that you mentioned, since you mentioned grade, that I hear frequently. Can the grade change? And if so, what would make something like that happen?
This is a great question, and a common one, and an important question. The grade can be different in different samples. I think this is an active area of research, and so it's evolving. And so what we know today may differ from what we know next week and next month, and certainly what we will know next year. It is possible for a given patient to have what is a well-differentiated grade 1, to have a progression and then have a well-differentiated grade 2 identified on that sample. I may even have multiple nodules, some grade 1, some grade 2. It can happen, and I would say it's not infrequent, and sometimes you can even see a well-differentiated grade 3. What is happening there is unclear if it's one thing happening. the questions are, is it progression or is it heterogeneity? Progression meaning that things are getting worse, or is it heterogeneity meaning that within this patient's tumor, there are cells that have a higher proliferative potential than others, and they kind of those different grades coexist
Mm-hmm.
in the patient. And I think that a definite answer to that is still pending, but certainly can happen. And usually the outcome of the patient is determined by the highest grade that is identified.
Mm-hmm. That makes sense. Well, thank you for that. Sean has a follow-up question. And his question is, what are the specific blood tests for a patient to use or request to help identify the presence of a NET causing the severe allergic type of symptoms and flushing? This is his question from previously. But so are there specific blood tests for a patient to use to help identify the presence of a NET?
Okay, so this is a good question. I think the specific blood test to kind of identify, to confirm that the syndrome or the combination of symptoms and signs you described, there are blood tests, and so from there they're going to look for. Or let me say that a different way. There are a number of tests that they can use to confirm that this is indeed carcinoid. So one of the things that they'll want to do is they'll look for catecholamines to make sure that this is not a common endocrine mimic, which is called paraganglioma.
Mm-hmm.
So that's a mimic. So they're going to do some blood tests to look for that possibility, and then we do a combination of blood and urine tests to look for serotonin and its metabolites to confirm that indeed this is carcinoid syndrome. So I think that there's a branch point there where we would need to consider the possibility of a paraganglioma and exclude that, and that will include looking for catecholamines, and to look for the carcinoid syndrome, we're looking for serotonin and its metabolites. In terms of a test to say, okay, this is specifically a GI net, or this is specifically a lung net, there isn't a specific there's not a specific blood test per se that points in that direction.
Mm-hmm.
One thing that can be done is a combination of blood work and radiology, looking with some special scans, for example, dotatate scans, that will help in a patient with carcinoid to localize where cells that would be responsible for carcinoid will be located. And so with that radiologic scan, together with that confirmatory blood test, looking for serotonin and its metabolites, we can identify in tissue, so in a person's body, where the responsible cells are. And so they will localize there based on their uptake of dotatate, which is a particular chemical. So that will help us to know where they are, where those tissues are. And sometimes that is enough to tell us this is where it is. Is that, and Sean, you can follow if
Yep.
he needs me to clarify more.
Absolutely. Absolutely. Folks, we're looking great. We've got over 100 people in the room today, and we are just halfway done. So we got plenty of time with Dr. Graham today. And I've seen, I'll send you all your accolades and superlatives afterwards, Dr. Graham. But the people are responding very well and appreciative of you and your answers. This is a question from, where did that just go? I lost it. Yes, from Beth. When should a second tumor biopsy be done? Should we wait until changes in symptoms, or what's the determining factor for that?
This is a really good question, and I think it's one of those questions that really is a multifactorial decision, like many decisions in healthcare are. And so it's really going to be best made by the physician or nurse practitioner who is seeing the patient. There are scenarios where if a second lesion is spotted where a biopsy is really important right away. There's scenarios where it may be okay to wait and to rely on observation with imaging. And what I do think is true is that I think your provider, whether physician or nurse practitioner, will be really happy to discuss that with you, discuss the possibility of doing a biopsy or observing just with imaging. I think they'll be happy to discuss the possibilities, both possibilities, and why to proceed with one or the other. And I think that's the way to go about handling that kind of decision.
Got it. Thank you. So we mentioned earlier MEN, multiple endocrine neoplasia. And so I want to back up and lay a little bit of groundwork there. This is, from a question from Denise, but in case anyone doesn't really know what we're referring to there, the question is, what is the difference between multiple endocrine neoplasia and neuroendocrine tumors, or like, do they go hand in hand? And so I want to give you an opportunity, Dr. Graham, to just let's establish, some foundation there about what exactly is MEN when we hear people say MEN1, et cetera.
Yeah. So this is a really good question, and I think it's important. So I appreciate it. It's important for us to get that background. Multiple endocrine neoplasia refers to a inherited disorder, a set of inherited disorders where a patient will develop tumors in two or more endocrine organs. So that's a specific specific definition and specific set of diagnoses. Most patients with well-differentiated neuroendocrine tumors don't have a syndrome, as far as we know, and that is true for actually all of the tumor types that I can think of now right off the top of my head. In most instances, most tumors develop in what we call a sporadic pattern, meaning that we don't identify a specific hereditary cause, something specific in their family that predisposes them to get that particular tumor. In most instances, tumors are developed sporadically. So their patient's mother or father did not have that, sisters do not. They have it, and they happen to be unlucky in that respect. It appears to be almost random, as it were. No, multiple endocrine neoplasia now refers to where patients have this propensity to develop tumors in two or more endocrine organs, and so that rare combination, the combination of those multiple rare events, is associated with a germline or an inherited genetic alteration. And so that's where these MEN syndromes come from and where they come in, but they are very uncommon.
Mhm.
They're very rare. To help put it into perspective in a way that might be helpful, in general, the probability that any genetic alteration is abnormal is of the order of 1% or less. So something that occurs with a frequency of greater than 1% is generally not considered deleterious or negative. It is part of normal human variation. And so the genetic events that need to come together for people to have a hereditary syndrome is really uncommon. And so in general, you're talking about things that affect less than 1% of the population. When you look at specific genetic abnormalities in groups, they're very uncommon.
Got it. Thank you. Next question. This is back to the biopsies. If a biopsy was never tested for NETs, and they're still able to access it, back to our previous question about storing it, can they be forwarded somewhere to be reevaluated?
So this is a good question. If a biopsy was taken for some reason
You're right.
and a diagnosis made and now stored, it can always be retrieved for reevaluation, provided that the materials still exist and there's still a sample to be tested. So sometimes there is a record that is maintained, so there's a record of it, or maybe pictures of it. But as long as there's actual material for testing, that is a possibility. And I would say, provided that there is a question that is clinically relevant. So we all have questions about things in the past. That's a typical thing for all human beings. But it doesn't necessarily mean that it is a high value to us.
Mhm.
So I think if a person has a doubt about a diagnosis, or I think perhaps more commonly, they're wondering if there's a new treatment that might be effective for them, or there's some new information, I would just reach out to their physician or to their nurse practitioner, and they will consider that possibility. And if needed, they can have that specimen retrieved and tested.
Got it. Thank you. And another thank you and shout out to Dominique, who just sent in a little donation. Facebook gives this thing they call it stars. And anyway, it's a way that you can contribute, and CCF functions off of sponsorships and donations. So we are always very appreciative. So I just wanted to say thank you. And I've seen a few more, and I'm sorry I missed you, but thanks, Dominique. And just wanted to let you all know in case, you felt compelled to send some Facebook stars. Okay. So from Ajid, I think I'm pronouncing that correctly. Ajid, you corrected me a couple of weeks ago. Anyway, Her question is, I'm often asked if my face shows redness when flushing. Being a black person, my face doesn't get as red as a sign of flushing as maybe someone of my complexion. So, what is your experience of flushing in people of color like me or like her?
This is a great question and an
Right.
important one. So this is a question though best for a bedside physician. So we work in the laboratory looking at tissue samples and diagnostics. So I don't have a wealth of bedside experience with regard to flushing as a symptom, how it is detected. I do think if she were to present with that as a symptom, and she were to raise that consideration, or say that she's been told that, or even that she has other symptoms that correspond to the carcinoid syndrome, I think it will certainly lead the physicians to follow up and to evaluate her accordingly. So I don't know the specific answer to her question because that's not a question that's not part of my practice. But I
Mhm.
think if she brought that question forward or brought forward a concern about being evaluated, I think that they would certainly be open to evaluating her.
Got it. Well, thank you for your question. Hopefully that helped give some guidance. Next question from Aaron. My carcinoid tumor is in my bronchial tube. I'm getting my dotatate scan next week. What's the most important question that I need to ask? I already have surgery scheduled to remove the tumor at the end of April. So this is I think a new journey for Aaron. I think you were here last week, Aaron. So, what's the most important question for Erin to ask for her dotatate scan next week?
So this
And
is a really
there
good
might be multiple
question.
answers.
Yeah, I think this is a really good question, Erin, and I think it's important, and I'm glad that you have your appointment set up and you're able to go in and to receive care. That is one of the things that I think a lot of people were worried about with the pandemic, but it's great that there's opportunities for patients to be seen and for their care to continue despite the pandemic. I think the it sounds like they have localized where your tumor is. It seems like they already have a plan. So I think the most important questions are going to be related to uh, your own or your personal the personal things that you want to consider, and not necessarily specifically questions about the disease. So you may want to ask about the scan is like, how what they're going to do in the surgical procedure, how long is going to be the recovery. I think you want to ask questions that refer to your personal considerations, how it's going to affect your life, how it's going to affect your work, going through the treatment process, because it sounds like they're already looking, preparing surgery, and you may want to ask them questions about the follow up. I think when the pathology report is back, they will meet with you. I'm certain about that to give you some information from there. But it sounds like you're already receiving information and that things are lined up. The important thing is to understand how this affects you or how it might affect you, and to ask them questions along those lines. I think those are probably the questions that you want to ask.
Got it. Thank you. And I appreciate you being back here, Aaron. We're here every week, so we're here to help. From Lynn, excuse me. How soon does a bland embolization begin to work, and how long does the procedure continue to work?
This is a really good question, and it's probably a really great question for interventional radiologists and so for not for a pathologist. The procedure should work immediately, in that those when we examine cells like that histologically, those cells, or no, those tumor cells have usually started to show signs of regressing or going away, and that appears to be an almost instant phenomenon. But I think it's important for her to discuss that with an interventional radiologist or the person who's doing the procedure, who could give her some real detailed information on it.
Mhm. Understood. Thank you for that. Dr. Graham, what about, let's talk a little bit, let's forecast into the future a little bit. What things are potentially coming up that you're excited about that'll help you do your job better?
So always, yeah, I'm really excited about that question. I think one of the things that we're looking at is a better understanding of those well differentiated nets that are grade 3, which have a proliferative rate over 20%. I think the opportunity to understand them better is really important, and to, I think, further distinguish them from poorly differentiated neuroendocrine carcinomas. We know that they're different. We know that there are some markers that help us make that distinction, with reasonable, I would say, sensitivity and specificity. But we're looking at new markers that will hopefully help us understand the difference. Platinum-based chemotherapy is often used for poorly differentiated neuroendocrine carcinomas, where patients may respond but may have a shorter overall survival. Patients, it would be interesting, I think, if we can develop more effective therapies in the future. That's something that I think is an active area of investigation. And then to have really robust options available for patients with well differentiated neuroendocrine tumors that are grade 3. So I think I would say the things that we're looking forward to, tools that allow us to distinguish the types of nets better, things that allow us to treat those patients better. We do have some treatments that are effective now, but there's still room for us to improve. So those are the things that I'm kind of like looking forward to happening in the future. Another big area, and perhaps this is the biggest area with the greatest potential, is can we come up with screening tests and a screening strategy for patients to identify disease early before it is spread? So before we're looking at flushing and all these different kinds of things.
What are your thoughts on the net test or your familiarity with it?
So I'm not super familiar with the net test. I'm aware of some other non-invasive tests that are being worked on, but I'm not, to my, as far as I know, they're not available commercially yet, or they're not clinically available. But I know that in research there are some tests that are coming out, and I'm excited to see them mature.
Are you able to talk about them at all? Like to be more specific, or
Oh, so I think at a high level, what I'm aware of is that people are looking at developing a non-invasive test, so meaning that you wouldn't need to test that you could do at home,
yeah,
markers that could develop at home, or that may be done in an outpatient procedure. You would come into the to a medical facility, kind of like you would go into a dentist, and that they would apply a test, and that usually within 24 hours you would know whether you have that disease or not. And
got it.
so potentially something that could be a blood test where a lot of things could be matched together as part of your annual physical and let you know whether there's something there or not, or it might be a sample that might be collected at home in a different way. The idea there being is that you're looking at identifying things before they become
Mhm.
overt tumors or large tumors. And so early diagnosis, if it's possible, offers a great chance at cure.
Mhm.
So I'm kind of looking at that space kind of in general terms and looking forward
Yeah.
to it.
It sounds like some of those things, like that you can do at home, et cetera, that applies to the net test. From my knowledge, I don't want to speak out of turn, but we've had so many questions about it, and we had on Dr. Maudlin, who created the net test. I just get so many questions about it. So I wanted to see what your thoughts were, but I know that's something that is commonly discussed currently. It's still kind of a new thing, so I'm glad to hear there are some other new things that would be a little less invasive. I think that'd
Yeah,
be great.
I'm familiar with Dr. Marlin and his work. He's a lot of amazing work for a very long period of time. But
Yeah.
I'm not super familiar with the net test. It's not kind of like in my area specifically.
Right.
But looking forward to all those non-invasive
Hmm.
opportunities that may arise for patients.
Gotcha. So Melanie has a question that I'm glad you asked, Melanie, because I was actually going to ask this earlier, based off of another question. But Melanie says 2 years into this journey, she is, and I'm still unclear of what KI67 does or how it relates to the proliferation of the disease in general. Let's talk about KI67. What is that?
That's an awesome question. So Ki-67 is the name given to a protein, and how that name was applied, it has to do with where that protein was actually discovered, and the antibody that was developed to identify that protein. And so that might be a little bit complicated, but I would say maybe the easiest and the simplest definition is that Ki-67 refers to a label that some cells pick up,
Mhm.
and the way that it was named had to do a lot with where that work was done originally. Now, aside from that naming convention or that naming portion, what it really refers to is a labeling of cells that are proliferative, cells that have the potential to multiply. And so some of the cells in our body are at rest, and so they will not be labeled by Ki-67. They're at rest. They have reached their term. They've reached their permanent terminal state, and
Mhm.
they're just hanging out. There are cells in our body that are multiplying, sometimes to repair things and sometimes to grow. What happens with Ki-67 in specifically in the context of NETs is that what it is identifying the fraction of the tumor cells in the sample that have the potential to multiply or that are multiplying. And so these are cells that are going to go through the process of making DNA and making more cells. Now, the higher that fraction of cells, the higher the fraction of cells making DNA and going about multiplying, the greater we call the rate of proliferation. And that rate is a feature of the aggressiveness of a tumor. So a tumor with a low Ki67 is making less DNA, is not trying to make more of itself, and so it is less aggressive in its behavior than a tumor that's trying to make more DNA and make more of itself. So a slower growing tumor is a tumor with a lower Ki67,
Mm-hmm.
and a faster growing tumor is a tumor with a higher Ki67. And so the number or the percentage in either instance will be higher. So how we make decisions is when we looked at the outcome of patients with well-differentiated neuroendocrine tumors, what we noticed is that a powerful predictor of the likelihood of the tumor coming back was the rate of proliferation. Or said another way, the Ki67. And so Ki67 helps us to define groups of tumors, those tumors that have the lowest proliferative rate, which is 2% or less, those that have a proliferative rate 3 to 20 currently, but certainly more than 2%. And then every increasing number, the likelihood of the tumor recurring increases. And so that's K67, that's what it does, and that is how we interpret it.
Got it. Thank you. Another question from Sean. This is back to the new tests that you were just alluding to. Are there any studies for those new tests coming up that we could participate in? And I'll expand that question too. And like we can talk about any potential new studies in general. But first, let's address that for those tests. Any studies that can be done for folks?
So that's a great question. None that I'm aware of, but I think his question is an important one. How do you participate in clinical trials, and how do you participate in research that will help yourself potentially and certainly patients in the future? I think when one is interested in that, just reach out to your provider and let them know. In general, there is an intake process for participation in clinical trials, and once they know that you are interested, there was probably a register or a log of interested patients, and they will reach out when opportunities exist. So if you let them know, at least I would say once a year is plenty often to let them know that you're interested in participating. Where opportunities arise, they will reach out and contact you.
Got it. Thank you. And folks, I mentioned this earlier when I was talking about the video database or library that we have. There is a video on clinical trials as well. So just look under our videos tab or on the YouTube channel, and you can see that. You might, if it's under the, I think we did that in 2020 series, so not too long ago. Folks, we have just shy under between 5 and 10 minutes left, so get in those questions while we still have Dr. Graham's time. Dr. Graham, remind me, well, how many of your patients are neuroendocrine patients, percentage-wise, if you know?
I don't know percentage wise. I would have to think about it. I would say something that, so in pathology we were making diagnoses, and in GI pathology we're making diagnoses on all the digestive system.
Right.
I would say that I encounter patients with neuroendocrine tumors every day. So at least I would say probably at least one every day.
Okay.
But I do encounter other things too, for example, adenocarcinoma and things that are not cancer as well every day as well.
But safe to say it's a big part of your practice.
That's correct.
Yeah. So my question is, I mean, what I do know about this disease, but from doing the work that I do with the foundation, is we mentioned this in the beginning, talking about mimicry, right? It's confusing. And it's confusing for a lot of the people who I advocate for here in our community. So let's pretend, I'm a newly diagnosed NET patient. What's your first piece of advice? I don't know what this type of tumor is. I've never even heard of it. What do I do so that I can give myself, be my best advocate, as you often hear people say?
This is a great question. I would say there are two things. I think this group is good to join this group to participate on calls like this.
I agree.
I think it's also good to reach out to try to participate in the North American Neuroendocrine Tumor Association, NANETS. And I think they will have a wealth of resources available for patients, and a lot of skilled experts are part of that group, and they'll have some patient-facing information and contacts as well. So I would say reaching out to those two groups, so groups that are involved in patient advocacy, patient support, are going to be very helpful. I think once you receive a diagnosis, in what will likely happen is that your initial provider will refer you to medical oncology.
Mm-hmm.
And I think when you go to medical oncology, you want to ask, I think, a range of questions. One of the questions will be, um, what do they think the next steps are? And to help you to understand the pathology report.
Mm-hmm.
So I think if they walk you through the pathology report, that's going to be really helpful. And so the pathology report will have the diagnosis. It will also include some information that describes how they were able to come to that diagnosis. And I think in walking you through that information, you will have an idea of how that diagnosis was made and what it entails. So you will know that, and I think that will reassure you as a patient, but also will help to figure out what will be the next steps. So I think walking through that pathology report, super crucial.
Yeah, absolutely. We have a lot of great comments coming in. Just thanking you so much, Dr. Graham. Sean, who we've heard from a couple of times today, says, thank you, Rain and Dr. Graham. These programs are always so informative. We really appreciate all the medical professionals who come on and are available for their questions. And I have to agree. I mean, you and the other experts that we've had on the show are just so open and available with their time, and I appreciate it, and I know the community does as well. So thank you for being here and sharing some time and your knowledge with us.
Sure, I'm happy to help. I think this is awesome, that you have this venue and that you're supporting patients and giving them information. With increased information comes the opportunity to I would think to do better, to have better outcomes. And I think to be better informed is always a good thing. So I appreciate the work that you're doing, Ray, the work that the group is doing, and I appreciate the engagement of patients who are asking really good questions. That's really awesome.
Absolutely. So folks, if again, as a reminder, if this is your first time being on the show, we appreciate you. We welcome you being here. Oh, Linda says Dr. Graham has been extremely informative, explains in layman's terms, and pathology is always in medical terms. So we hope to see him again. You know what, Linda? I hope that as well. So that's so important to explain it in a way that people can really understand, because this is confusing and scary at times.
Yeah.
So I appreciate you doing that. And folks at home, I always appreciate you being here. This program doesn't exist without you. So we need you here to be part of the community and ask these great thought-provoking questions that you do every week, and continue being your own best advocate. You all do a great job. Maurice, I unfortunately missed most of this. Will be available to watch on Facebook. Maurice, it'll be available in like 2 minutes on Facebook. It'll repost itself right there under the videos tab. It'll be the first video, and it'll live there evergreen. It'll be there. And then for anyone who doesn't have Facebook, rather, it'll be on YouTube next week, and you can let them know. So watch the replay, go through the library. And again, one more time, I will reiterate, reach out to CCF either here on Facebook. You can just send them a private message, or at carcinoid.org, and they will get you the information that you seek, or the information of the person who can get you the information that you seek. We also have to thank our presenting sponsor, Ipsen Biopharmaceuticals, for being here to support us every week. We couldn't do the show without them. And finally, folks, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next week on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.